reminded, if you don't mind, some nostalgic memories about the science of psychiatry and how some of these drugs were first introduced. I don't know how many of you know this when you think about the current FDA and what it takes to use a medication. I bet you don't know how Thorazine was introduced, but I'll tell you. Not how it was discovered, but how it was introduced in the United States. Any of you remember Heinz Lehmann? He was Professor McGill. Anyway, one of the grand old guys. He was in London with his chief resident. This is about the end of 57, 58. And met Denneker. Denneker and DeLay were a couple of people who discovered Thorazine. You know, at least said, hey, it's quieting down our patients preoperatively. They were using it as a preoperative medication. Heinz was one of the people who says, well, maybe we can do something with that with our patients on the wards who are so excited, you know, just off the wall. And he gave it to his chief, he got a whole box of the stuff, chlorpromazine. Gave it to his chief resident who was going back to Montreal that night. Says, try it on our patients. The resident went back, I think it was Saturday night, and then when Heinz got there Monday, the resident met him and says, the ward is half quiet after just 48 hours. Something's happening. And that's how it started. Then it filtered down over the border into the United States later. So that was the approval that was necessary for a new medication in those days. But by the way, haven't you noticed that effective stuff, really effective stuff, probably doesn't require study, like penicillin? There was no double blind with penicillin, chlorpromazine, etc. Just little stories. Nate Klein, who first used antidepressives, anybody know that story? I don't know why, but he was involved in a TB SAN in those days, doing some consultation on psychotic people, and noticed that when they were being given iproniazid, which was an anti-tubercular drug, they started having a better mood. So he started using MAOs for depression. That's how the whole thing started, an observation. Wrote a little book called From Sad to Glad, and won the Lasker Prize after that. And of course, I'm just musing about our great science, and in fact, how essentially most of the great discoveries in psychiatry have been accidental or just good observation. You know, or like lithium, which was not supported by any company, which had been used for well over a century, off and on for mania. And by the way, I just remembered something I never did before, which was to encourage someone to look into mid-19th century lithium, where it was used for what they called gouty mania. Believe it or not, people gout apparently got high, some of them, and they used lithium. To my knowledge, no one has ever looked at the relationship between uric acid and mania. And so God knows how. But take a look. You'll find it in the books. There are a lot of stories like that. Okay. Quickly, I'll go through fast, the edits. Okay. 2 or more SSRIs for 60 or more days. Actually, I see no reason why anybody should be on 2 SSRIs for any days, but that's another story. That's my feeling. 2 or more tricyclics for 30 or more days. See, I think you're being overly generous. Really, really overly generous. 3 or more antidepressants for 90 or more days, single prescriber. Because remember what Bob said. You know, when you start looking into the data, you find out there are often multiple prescribers for the same drug. And you don't know how much the patient's taking or selling, of course. SSRI and SNRI combination for 60 or more days. I think that's outrageously generous, in my opinion, because of the possibility of serotonin syndrome. We'll talk about it later. Maybe somebody can give me an idea of why you'd want to give an SSRI and an SNRI at the same time. Okay, I'll wait. Concurrent use of 2 or more antipsychotics for periods of 60 or more days. concurrent use at any time of 3 or more antipsychotics, and high doses and so forth. I won't belabor it beyond that. Those are the biggies. And as I say, they're really not a hell of a lot different from the way they were years ago, except for the SNRIs, which weren't sold then. So what can I say, except that you know, we're treading water so much here in this strange field of psychiatry, trying to make, quote, scientific something which still, in many, many ways, is an art form, and in which, unfortunately, what may be the biggest and perhaps most significant kind of treatment for all of these conditions is not often mentioned, so I'll close by mentioning it. And that is psychotherapy. Now, mind you, I'm not listing what kind, what framework, what cult you have to belong to, what name you're relating to, but the ability of one human being to relate to another in a way that presents or conveys some understanding and humanity to that person. There's nobody who denies the importance of it, and we never talk about it enough. Now, please don't ask me who's going to pay for it. Please don't ask me how we're going to see to it that everybody gets it or who gets the training to do it, because they're, as you know, almost erasing the training of psychotherapy in psychiatric training programs. So probably before long there won't be any training in psychotherapy in psychiatry. Who knows, maybe I'm being too pessimistic. The point is, no one talks about it, even for the psychotic patient. Perhaps even more so for him than anyone else. So I close with that. Thank you all very much.